Thank you so much for all your patience. Learnit is India's largest live digital CMA and doctors generated medical content platform. Our website is www.learnit.com, where we have lots of live sessions conducted by eminent speakers across the globe. And we have made wiki services, which is medical Wikipedia for doctors. Only that also you can read in your leisure time. We will invite all the doctors to visit our website. Now, without further delay, I would like to hand over this session to Dr. Muralidhar. Over to you, sir.
Thank you, Sweta, for that kind introduction. And I'm indeed delighted and proud to invite you for this 146th episode of ICA Webinars. It is 146th. We started sometime in July 2020, and we'll be shortly doing the 150th webinar on the 31st of this month. Please join, it's going to be interesting. And to join the ICA, this is the membership form, which is available on the website. And next is we are one of the unique organizations which bring out yearbook of anesthesiologists on a regular basis, on an annual regular basis, which is well appreciated and well received by the practicing anesthesiologists as well as the trainees in anesthesiologists. Regarding the upcoming events, this Saturday we are having a critical care echocardiography one-day seminar in the Jaideva Hospital to go through the echocardiography meant for critical care purposes. It is useful for the upcoming anesthesiologists and critical care specialists. And we have the 150th webinar coming up on the 31st May. And today's program is the contemporary issues in ICU. All my faculty members are young, enthusiastic people, and with a lot of stuff in them, and we would like to listen to them today. And my moderators are including me. Next slide, please. I'm the Director Academic of Narayana Hrudayalaya, Narayana Institute of Cardiac Sciences in Bangalore. We have Dr. Rajesh Mohan Shetty, who is the lead consultant and chief of clinical services, Manipal Hospital, Whitefield. He's very well known for his interest in critical care sonography, and they're experts in ECMO. The next moderator is Dr. Arjun Alva. He's the administrative head and consultant critical care medicine in Narayana Hrudayalaya Mazumdar Shah Hospital in Bangalore. He works with me. He's again young and enthusiastic with a lot of energy. And the third moderator with me is Dr. Karthik Rao. He's a senior consultant, Manipal Yeshwantpur, and he's interested in mechanical ventilation and neurocritical care. With this introduction, we would like to proceed with the actual scientific program. To begin with, I will request Dr. Rajesh Shetty to invite the first speaker and introduce the speaker, and the session will start from that. And I request the audience to post their comments or questions on the chat box, which will be transmitted to us. We will take all the questions at the end. Thank you so much, and Dr. Rajesh Shetty will lead the team. Dr. Rajesh Shetty.
Thank you, Dr. Muralidhar, and good evening all. Welcome to this fantastic session of Academic Feast organized by ICA and specifically Dr. Muralidhar. The first topic is about evidence-based medicine. As everyone would agree, this is the cornerstone of modern medicine. Especially in recent years, you can say that there has been an explosion in available evidence to guide our clinical management. And there has been a great increase in the quality of the research with improvement in research methodology as well. Having said that, there are lots of challenges a lot of research says that the quality of some of these studies is very poor. Some of the results are actually not correct at all. And I am sure you and me, we see on a regular basis, even very good clinicians sometimes don't follow evidence-based medicine. So to answer the challenges you come across practicing evidence-based medicine, and especially how to look for and adopt evidence-based medicine, we have our first speaker, Dr. Kiran Gowda, who has come from, I can say that the home of evidence-based medicine. He's talking straight from United Kingdom. He's a specialist in anesthesia and critical care at Morecambe Hospital, and I understand he's the UK lead for audit as well. One of the important cornerstones of quality and evidence-based medicine itself. And he has won a lot of awards, including Best Paper Award. Welcome, Dr. Kiran, and please go ahead.
Thank you very much for the introduction, Dr. Shetty. At the very outset, I would like to thank Professor Muralidhar and the Indian College of Anesthetists for giving me an opportunity to be a part of this webinar. If it is okay, can I share this screen?
Yes, please.
Can you all see my screen?
Yes.
Am I audible?
Yeah.
Okay, thank you. I don't have any disclosures, Dr. Shetty. So talking about evidence-based medicine, that was a very apt introduction by Dr. Shetty about evidence-based practice. And what exactly is it? Most people think this as a jargon of words, and how to implement this evidence-based practice in day-to-day life. That's one of the important questions. It's a conscientious, explicit, and judicious use of current best evidence in making decisions about the care of individual patients. And use of mathematical estimates of the risk of benefit and harm derived from high-quality research on population samples to inform clinical decision-making in the diagnosis, investigation, or management of patients. The first and foremost step is, or the step one, how to formulate your inquiry. Ask questions in the right format, which is the PICO in the context of time. So patient population of interest, intervention or area of interest, comparison group, if any, and the outcomes. All this in the context of the right time frame. If I search for any particular evidence, that search is only valid for that particular time. So we should not ignore time factor and search for the best evidence on electronic databases. A literature search should be on published data on grade literature as well, which is unpublished but relevant and obtained by writing directly to authors. The search should be at least on 2 electronic databases, and citation chaining is essential. Choose the right data extractors and devise a search strategy. The raw database and indices are Ovid Medline, Embase, Scopus, Sinahel, especially for nurses, Global Health, Google Scholar, and Science Direct. And there is a host of prize articles which you can find from Cochrane Controlled Clinical Trials, Health Technology Assessment, NHS Economic Evaluation Database, which is more valid for UK, Evidence-Based Digest, NICE guidelines, and Scottish or SIGN guidelines, which are also more familiar with clinicians from UK. And coming to data extractors, I've just given an example on ARDS or acute lung injury, and outcomes we are looking for is mortality and in adult patients. So we can devise these as data extractors, and the search methods or initial search involve, let's say in Cochrane or Ovid Medline, Embase, Scopus, from 1996 to current. You can choose only the last 5 years to look for contemporaneous evidence. However, there will be some landmark articles which could be missed, not present in the last 5 years. So it might be a good idea to start, maybe from the last 2 decades, and then you can. I'll come to that how we are going to basically, exclude irrelevant articles. A backward chaining is extended search to include seminal work relevant to the review is important. And you can also have some limit your search options to review articles, full text articles, depending upon the sex, male or female, humans, age group, if you're looking for pediatrics or adults, or if you're looking for geriatrics, you can basically limit based upon whatever you want to look for. Exclude or include abstracts as well, the publication years, English language, and the date accessed. So if I did an ARDS, when I did an ARDS, search for mortality and outcomes in the year 2012, this is what I got, from 2006 to 11, 16 hits on Ovid, 48 on Scopus, 2 on Sinahel, Science Direct, 253 hits on Cochrane 1. Then I have excluded all the abstracts because I am looking for basically full text articles to obtain backward chaining and cross-referencing articles as well. So the relevant studies have been chosen from each of these data search engines, and this has been clubbed into like this, with systematic reviews and meta-analysis 1, RCTs 5, cohort studies 3, case control studies 2, editorials 3, Cochrane 1, surveys 2, case reports 1, gray literature, theses or internal reports are non-peer reviewed. Now, some people would think, all the dissertations, what we usually submit to universities towards our masters is if it is not published in journals, would that be not relevant? Yes, of course it is relevant. This is called as gray literature. So if you know someone who has done work in that particular area, you can always contact the author directly, or the national board, or your university, and obtain a copy of it. Cross-references and back-chaining and raw data can also be used. So coming to critical appraisal or evidence of assessment and methodological quality. So these are some of the important statements and papers which one should be aware of. For systematic reviews and meta-analysis, it's a PRISMA statement. I will individually deal with each of these in the coming slides. Randomized controlled trial, consort, cohort studies, case control studies, case reports, etc., can also be assessed and critically appraised using the CASP skills, or which is also called as Critical Appraisal Skills Program from Oxford. Or you can also use a JBI approach, which is Joanna Briggs Institute, which is one of the biggest institutes, especially for evidence-based medicine. It's from Adelaide, Australia. So you can also have, if you don't want to take the effort of looking into and critically appraising articles, you have pre-appraised studies from Cochrane and health technology assessments and NHS economic evaluation databases readily available for you to apply in day-to-day practice. Coming to systematic reviews, it's a brief overview of clearly formulated question that uses a systematic and explicit. Sorry, just a second. Methods to identify, select, and critically appraise relevance research, and to collect and analyze data from the studies included in that review. A meta-analysis is a statistical synthesis of the numerical results of several trials, which all have addressed the same question. Here, the advantage of meta-analysis where we can combine the outcomes of smaller individual trials, which may not individually show a significant meaningful effect, but contribute to a pooled result which is statistically significant. So this is a PRISMA statement with a checklist. In 1996, the quality of reporting of meta-analysis was published. And in June 2005, there was a 3-day meeting in Ottawa, Canada, to revise and expand quorum statement that gave rise to PRISMA, which stands for Preferred Reporting Items for Systematic Reviews and Meta-Analysis. And it was published in 2010 by Moher et al. And updated in 2021. It has got 27 items on the checklist and a 4-phase flow diagram. This is how authors are expected to report any systematic reviews and meta-analysis in trials, also for publications. Sorry, I'm unable to see my slide on the top because of this. Yeah, okay, I got it. Randomized controlled trials. provide an accurate estimate of average treatment effects of groups that differ only with respect to intervention of interest when adherence is perfect, blinded, and randomly allocated interventions. It is considered to be of high quality evidence. So CONSORT is the Consolidated Standards for Reporting Trials, is a checklist of essential items of, I think it's 25, and with a flow diagram. This is a statement which is considered to be like the Bible for authors who want to report any randomized controlled trials. So it starts from title and abstract and includes, statistics, the methodology, and the external validity as well. So the Critical Appraisal Skills Program from Oxford provides a checklist for randomized controlled trials, systematic reviews, cohort studies, case control, economic evaluation, diagnostics tests, qualitative studies, etc. There are 12 questions which one has to answer to appraise a particular cohort study or an observational study, let's say. So clearly focused issues, how is the recruitment? Is it acceptable? What is the bias? Reliable measurements of outcomes, and are these measurements reproducible as well? Confounding factors, follow-up, or any loss to follow-up. Results, do you actually believe in the results? Look at the precision of results in terms of confidence intervals, applicability to local population, homogeneous or heterogeneous results, and implications and limitations. So one should be familiar with this bias. There are plenty of biases actually, and the most important ones are the selection bias, technical bias, consent bias, dilution, publication related, resentful demoralization, analytical, especially in terms of randomized controlled trials where we follow the intention to treat principle, subversion bias, attrition, ascertainment, recruitment, Hawthorne effects, and delay. I'm not going to go into the details of these bias because that itself is going to take a long time. And one should be familiar with these statistical studies, the hypothesis testing, the null hypothesis and the role of chance, the p-value determination, interpreting results with good sample size, confidence intervals, relative risk, absolute relative risk, as well as odds ratio, number needed to treat or NTT, correlation and regression coefficients, and the tests which are for paid and unpaid tests, including ANOVAs. The synthesis of evidence is what you're going to get at the end of critical appraisal, which is close to the end of the review process. Accumulate the evidence and extract the data, making sense of available evidence in the form of an argument, theory, or conclusions. So this is the hierarchy of evidence which was initially published. And if you can see at this pyramid, meta-analysis or randomized controlled trials were always on the top. And then comes the randomized controlled trials, observational studies, case reports, case series on non-systemic clinical observations. However, things have changed in the recent past. Randomized controlled trials, we all know the advantages and disadvantages. They offer rigorous methodology and evaluation of single variables, offer prospective design, use hypothetical co-deductive reasoning, which is basically establishing cause-effect relationship, potentially eradicates bias, allows the meta-analysis, but the disadvantage being expensive and time-consuming. Smaller trials funded by large bodies may influence the results, giving rise to a bias, and the generalizability or external validity of the study is not often very great. On the contrary, observational studies have a lower cost, timeliness, greater treatment effects, generalizability, and less bias, but the disadvantage being confounding factors which can distort results, difficult to determine cause-effect relationship. So observational studies have several advantages, have we discussed. There was a study by Chalmers et al. Who showed 56% of non-randomized clinical trials showed familiar results compared to 30% of blinded randomized controlled trials. And the other bit is a meta-analysis of 14 meta-analysis. Please listen to this, it's very interesting. The meta-analysis of 40 meta-analysis compared more than 1,000 pairs of observation studies and RCTs across 228 medical conditions and found effect estimates from observation studies were not significantly different from RCTs. The majority found minimal disagreement between RCTs and observational studies. And the healthcare outcomes were assessed with observational studies designs compared with those assessed in RCTs, which is also published in Cochrane database in 2014 as well, which basically, they try to say most evidence show that observational studies and the RCTs usually agree, but sometimes not. When they disagree, one should explore flaws in internal validity and limitations in external validity of these studies. A comparison basically show the estimates of the effects of the treatment in observation studies and RCTs were similar, except for a small amount of studies, and the magnitude of effect is in combined observation studies lie outside 95% of for RCTs in a very small amount of literature. So coming to the limitations, we already discussed the confounding factors which can potentially distort the results. So they propose a new hierarchy of evidence where you can see that both randomized controlled trials and observational studies exist with consistent findings. Meta-analysis takes the second priority with RCTs or observational studies as well. And the bottom is the non-systematic clinical observations. This is what the newly proposed hierarchy of evidence now. Joanna Briggs Institute from Adelaide basically proposes the levels of evidence. So after the synthesis of evidence, we need to classify this to the levels of evidence and the recommendations as well. Level 1 goes for experimental designs with systematic reviews of RCTs and pseudo RCTs. Level 2 is quasi-experimental designs. Level 3 is observational. Level 4 observation studies with descriptive studies, and level 5 is expert opinion bench research. The grades of recommendation being grade A and grade B. A strong recommendation is where it is clear that desirable effects outweigh undesirable effects of strategy. Where there is evidence adequate quality supporting its use, there is benefit or no impact on resource use, and values, preferences, and patient experience have been taken into account. A weak recommendation is where the desirable effects appear to outweigh undesirable effects of the strategy, although this is not as clear. Where there is evidence supporting its use, although this may be of high quality, and there's a benefit, no impact or minimal impact on resource use, and the values, preferences, and patient experience may or may not have been taken into account. So when I did one of the dissertations for my master's in critical care, I chose to basically do a systematic review on safety and efficacy of high frequency oscillator ventilation. And these are some of the studies which were included for the systematic review. And as you can see, based upon the JBI recommendations in 2014, these were classified into the levels and the grade of recommendations. So that is how we can arrive at conclusions. Basically, no evidence is useless. Basically, it all depends upon the methodology. Step 4 is integrate the evidence with clinical expertise and patient preferences and values. Generalizability or external validity is very essential. These apply the results and reflect in current practice and patient populations. This is where the randomized controlled trials fail most of it. There was a study which was conducted to see how many of all these RCTs are really applicable to day-to-day practice. I think if I remember correctly, 55 RCTs could not be, did not show any significant difference. And there were only 10 RCTs which showed a positive effect and which could have been applicable to day-to-day practice. So this is essential. And JBA has also published a FAME approach, feasibility, appropriateness, meaningfulness, and effectiveness scale, which might help inform the wording and the strength of recommendations. Step 5 is to evaluate the outcomes of practice decisions and monitor the effect of evidence-based practice change on healthcare quality. Step 6 is to disseminate evidence-based practice and share experience and dreadful outcomes to improve healthcare. There's no need to hide, there's no blame game here. These are some of the references. I hope I've completed my presentation with the allocated time. All I have to say is, importantly, please do not ignore observational studies, or it should not be considered. It should be considered complementary to RCTs rather than inferior. High quality observational studies provide valid estimates of exposure and may be more generalizable. RCTs provide robust internal validity and unbiased estimates, but may be less generalizable. So it's not, the validity of a study is not entirely determined by the choice of the study design, is rather than a comprehensive evaluation of the quality of individual studies. Thanks, everyone.
Thank you, Dr. Kiran. That's an excellent presentation. And Dr. Muralidhar, can we take the questions now, or you want to go with the next
The
session?
questions will be at the end of all the presentations.
Okay.
The questions will be at the end of all the presentations.
Sure. I think in that case, we'll go to the next presentation, I think, and we'll take the questions in the end. In the chat box, I think maybe all the delegates can put their questions so that we will have a list of questions to answer at the end.
Yes, yes.
Sure. Thank you.
Thanks, Rajesh. So going to the next speaker, my name is Arjun. I'm one of the ICU consultants working for Health City. So the next speaker is Dr. Vimal Bhardwaj. He is a consultant intensivist at NH Health City. We are colleagues, we work together. He's got a very keen interest in fluid dynamics. He has done a lot of research on effects of the fluids on hemodynamics. He is also a very, very keen researcher in what is called as VEXIS, which is quite popular nowadays, which is venous access with the use of ultrasound. And we as a group of intensivists across Bangalore and across the country, we are also doing a randomized controlled trial on this VEXIS study as well. He is also a program director for a hospitalist program, which is aided by the government of India, which is a critical care training program of 18 months for post MBBS students. Today, Dr. Vimal is going to talk about frailty in ICU. Over to you, Vimal. Please take over and.
Thank you for the introduction, Arjun, and thanks for the opportunity, sir. So in ICU, one is always torn apart with these decisions, very key decisions, because sometimes you play God over there, and you tend to determine who lives and who might not, when to withdraw the support. So this question everyone would have got in their minds, those who have been working in ICU for a very long time. Is age a sole determinant for prognosis or treatment consideration? So that's George Bush at the age of 75, 76. He's going on a solo parachute. So he's probably healthier than me at that age, 75, and he's diving out of the aircraft and landing safely. So will you consider aggressive treatment in this if he gets admitted? Unfortunately, it's no more, but someone who is as enthusiastic and as healthy even at that age group, will you consider what it takes to make them survive? So chronological age is not a universal predictor of poor clinical outcome. So in our hospital, I'm proud to say that our surgeons have operated on an 87-year-old man, CABG, who came from US, and he had wonderful recovery. Within 1 day, he got extubated. Within 2 days, he was in ward. So age is not a poor predictor of a poor clinical outcome predictor. Not always. So in order to answer this question, one needs to know what is a frailty syndrome. So it is, in simple words, I hate definitions, so I will just put it in a simpler word, the ability of a person to recover or to cope up with any insult, and which is independent of chronological age, is what is the concept of frailty syndrome. I will repeat this definition again: independent of chronologic age, ability to cope up or recover from physiologic insult. So, as age progresses, yes, definitely the physiological reserves definitely do come down. But that doesn't mean that younger age group have got full capacity to cope up with any stress of illness, and the older age group doesn't. So it all depends on the kind of damages that the patient has undergone over a period of time. Apart from age, there are various mechanisms which can contribute to frailty syndrome. Important among them is the imbalance between anabolic and catabolic hormones, the oxidative stress, and the habits of the patient, smoking or any other chronic drinkers. And apart from that, the pro-inflammatory mediators, the kind of diet that the patient can have, lifestyle, and the phenotypic changes, and even the genetic factors play a pivotal role in determining the physiological health of the patient. So these are, in short, some of the mechanisms which, along with age, can be some independent predictors of the physiological reserves of the patient. So this frailty has been defined, or has been, they have tried to measure frailty by different indices. So one index has taken purely a physical phenotype, wherein they have looked at weight loss, decrease in walking speed, daily physical activity, grip strength, and the patient's sensation of exhaustion. So this they have tried to define as a physical phenotype. The other models that have been proposed to define frailty is accumulated deficit model. That is, they have taken comorbidities, some of the laboratory abnormalities like BNP, disability, and symptoms of the patient, and a multimodal tool which encompasses psychological impairment, limited social support, biological abnormality, financial limitation, cognitive impairment, and physical impairment. We all are quite busy doctors. So if we have a scale which is as exhaustive as this, then it becomes very cumbersome to implement this. Already the paperwork is increasing on a daily basis. So these models, although they have been useful, but when it comes to the practical applicability, has got its own set of limitations. So how are these models useful? So what about a preoperative patient? So based on frailty, one can have, if there are any inadvertent events during the operation, then how far should we go to resuscitate the patient? And we will have an objective scale by using a frailty index. We can define which all patients are high risk, and we will be able to prognosticate the patient before the surgery itself, so that the family can be well prepared. And there are studies which are evaluating, based on a certain frailty tool or number, whether the patient requires optimization. The optimization might ensue a slew of physiotherapy exercises, along with nutritional and probably the psychological assessment of the patient and optimization of the patient, and whether anabolic steroids have got any role in optimizing these patients. So all are being under research model. We do not have any paper which can guide us through if so-and-so is the frailty model or the number, whether all these interventions have got any benefit or not. But this is a thought process which might be useful in putting it across as a number to the patient, saying that they are for high risk, and to what extent should we do the resuscitation. So among all the frailty tools that have been that have been proposed, the most commonly used frailty tool is clinical frailty scale. So it looks at the physical activity, functional status, and chronic illness burden along with cognition. So it is quite easy. Actually, frailty scale has been very easy to use, and if you know the scale, you can probably prognosticate the patient within a matter of a minute's time. So clinical frailty scale. So this is the scale. First three numbers means patient has got good physiological reserve. That is, patient is very fit, well, or managing well based on the physical activity, whether he works out regularly or not, how enthusiastic he is, and whether is he a seasonal person. I'm a very seasonal person. Sometimes I do get the urge to exercise, and sometimes there might be many days wherein I might not exercise. So I might probably fit into clinical frailty scale 2. So 3 is managing well, but they're not very active. They do not exercise regularly. And those who have got some medical problems, although well-controlled hypertension or diabetes, so they come under grade 3 category. So 4 is the deciding number. So 4 are the patient group which are vulnerable. They are prone for increased severity of illness because their physical activity is not great. They are slowed down and they feel odd all the time. They are tired and they do not have a very active lifestyle. So these are the patients who are vulnerable at contracting any major illness and the associated complications of it. 5 and above, 5 to 8 is the one that means to say that patients are quite frail. The incidence of adverse events are quite high in this age group, in this patient group, and especially grade 7, the mortality of these patients is close to 10 to 11%. And 9 is terminally ill. The chances are of patient making up is quite low. So this is what the scale means. So higher the score, greater the chances of developing complications. And we can say that those who have got advanced score, patients might not do really well. So CFS, so now you have got a patient in front of you who has been bedridden for the past 3 days because he has been coughing or an altered sensorium. Do we say that he has got a clinical frailty scale of 9 because he is almost bedbound since 3 days? No. The time period that you are looking at is at least 2 weeks back before contracting the illness. What was the patient's lifestyle? Please remember this time frame. 2 weeks back, what was the patient's physical activity? Do not base your judgment based on how you perceive the patient. You might see that the patient, and you might get bias saying that, okay, this patient is not going to live, seeing the list of the illnesses that the patient might have. But it is very important to see what was the patient undergoing 2 weeks back before contracting the illness and what was his lifestyle. So it's very important to have a cross-check. With multiple patient relatives, because even the patient relatives' history can be very, very subjective. So it's very important to check for the authenticity of the history. Be very careful when it comes to defining a patient with clinical frailty scale of 6 and 7, because the mortality difference is quite huge. Those who have got a grade 6, the mortality is around 6%, 7 almost exceeds more than 10%, that is 11%. And when should you do this clinical frailty scale? As soon as the patient comes to the ER, it's good to have a clinical frailty scoring done, along with the early warning scores. So for any scale, you can do justice to the scale only if you know the limitations. Can we take it as a single yardstick to determine the prognosis and how aggressive you can be on the patient when it comes to clinical interventions? Absolutely no. You should not base your judgment only based on a single clinical frailty scale. The limitations of this scale is that there are no studies which have examined the utility of clinical frailty scale in less than 65 years of age group or in those with learning disability. What about a patient who has got a cerebral palsy? He might be living the same lifestyle for 40 or 50 years. Can we implement this scale in someone who has got a stable, chronic, long-term disease? No. It has got its own set of limitations in these patient groups. So again, repeating, limitations are that it is not a great scale. None of the studies have in fact seen whether the performance of the scale in less than 65 years of age group. And in those patients who have got long-term, stable, chronic disability. So what should be the future of frailty? So I'm just giving my inputs after going through most of the literature, that we need high quality studies in order to ascertain whether clinical frailty scale is a useful index in younger age group, that is less than 65 years of age. And we need to have a newer frailty scale, which looks at the bone mass, which looks at the ultrasound evaluation of the muscle mass as well, and other biochemical mediators, because these will add more objective component to the clinical frailty scale and might bring in more and more information on how aggressive we should go about. So the take-home points are, it does bring in some objectivity in deciding the prognosis of the patient. The clinical dilemmas of when to stop the aggressive treatment might have a more add-on with the addition of clinical frailty scale, although it is not a sole index on which it has to be relied upon. And the decision of when to stop is determined by the acuity of illness, severity of illness, the patient's response, the physiological reserve, the socio-economic support that the patient has got. So all these parameters have to be taken into account in order to make this critical decision of when to stop treatment. This is by no means a sole yardstick to determine when to stop the treatment. And please remember, it is not reliable in age group of less than 65 years and in stable long-term disability patients. So I will just give you one case, a very interesting case that we struggled in our ICU. So that's a 59-year-old gentleman. He was post cardiac transplant, 6 months, post cardiac transplant 6 months. And he has been having multiple medical problems. So he came to us in septic shock. And apart from that, he had GB syndrome. He had candida growing in the blood. Apart from candida, he had pan-drug resistant Klebsiella. There were mycotic aneurysms. And he was on ventilator for severe GB syndrome. He was undergoing plasmapheresis and all this. So there was a debate between the ID specialist and the treating pulmonologist versus the intensive care team and a set of transplant cardiologists. Whether should we stop treatment? We were not for withdrawing the care because it was still a reversible factor. There was a great amount of reversibility because there is a bacterial infection which can be treated. There is a fungal infection which still has got drugs. GB syndrome can still be reversed with the plasmapheresis and other modalities. So why not just give the standard care and see whether the patient improves? So after 2.5 months, he is being discharged from the hospital and he's walking out of the hospital. So it's a sight to watch. It's just that many a times the clinical decision making will be quite precarious. you will find patients who will, you would find that there is no point in continuing the care. But having an objective mind, looking at all the scenarios might bring in more quality, and also in determining when to actually stop the treatment objectively. So that ends my session. Thank you for the opportunity.
Thank you, Vimal. I would like to hand over to Dr. Karthik Rao, who will introduce the next speaker. Dr. Karthik.
Hi. First of all, thanks to Murali sir for organizing this lovely webinar. His enthusiasm is quite infectious. Thank you, sir. Thanks for the invite. We move on to the next topic, which is end of life. This talk will be delivered by Dr. Shivakumar, who is an associate consultant intensivist at Narayana Vidyalaya and Majumdar Shah Hospital. His areas of interest are critical care echocardiography, critical care nephrology, and trauma. We actually are dealing with the situation probably every day in our ICU practice. And the whole concept of ICU comes to the point where we always decide whether curative effect is better or prolonging life and delaying death is a way to go forward. So over to Dr. Shivakumar to deliberate on this topic and give us a few points.
Yes. Thanks for the introduction, sir. Thank for giving the opportunity to ICA. So without wasting much time, we'll just directly go to the talk. So I'm going to talk about end of life care, the current situation in India. So what is the issues that we're going to deal with. So I don't have any disclosure in my talk. So I'll cover my talk under the following headings. So the basic definitions that we have of the terms used when we use end of life care. So what are the ethical, moral, and legal angle to end of life care? We have what are the guidelines from various societies that are there in terms of the implementation of end of life care. So in 2023, where do we stand from a legal point of view? So what do the laws say? How to implement end of life care in your ICU? And in the end, to sum up, we will just briefly touch upon how to apply end of life care in your ICUs the best possible way. So a few months back, the Queen of England, Her Majesty, died in her castle, Balmoral Castle, peacefully. She was terminally ill, supposedly, but she was not admitted to the ICU. In compared to the Indian setting, if you're a VIP, you end up landing up in ICU. You're an ECMO, you're in multi-organ support, and in the end, you're going to most of the times you're going to die in the ICU. So dying in India is not a good place. That's what numbers suggest. So when you look at the quality of death from the Lion Foundation of Singapore, India ranks very much lower. So the rank of India is about 59, where they've looked at what is the quality of death in ICU in all over the world. So if you most of the European countries, UK is much ahead, whereas India is much lower on the ranking. So in terms of the quality of death. So when you look at numbers of ICU patients who are actually, how many patients are we really offering end of life care? So there was this study from Dr. R.K. Mani in 2015 where we looked at multiple ICUs where we compared Indian ICUs to European ICUs, where what are the percentage of patients where we are actually offering end of life care. But the actual percentage of patients where we're actually offering end of life is much less compared to European ICUs or United Kingdom. So we have another study from India where it is a cross-section study, the INDICAPS 1 and INDICAPS 2, which actually looked at multiple ICU factors. You can see in this study, the terminal discharge rate was very high. It's about 6 to 7%. So 7 out of 100 patients admitted to the ICU are getting terminally discharged. They're not dying in the ICU. We're not offering end of life to these patients. So that is a significant number of patients who are getting discharged. They're either getting discharged against medical advice, they're going LAMA. We're not able to offer end of life care to these patients. So what are the problems in offering, what is hindering us as an ICU treating physician to offer end of life care to these patients are the most important points are we are worried about the legal implications. So am I going to get into a lawsuit when I do end of life care, when I implement and the patient dies in the ICU. And most often in Indian settings, the patient is going to pay from his pocket, unlike other countries. So the patient has financial issues; they're not able to pay for their ICU stay. So once the patient is critically ill, when we say the poor prognosis, they're going to take the patient discharged against medical advice. There is lack of awareness among the treating team as well as the general public about the end of life care issues. And sometimes there is an apprehension from family. When we write a comfort care or withdrawal or withholding, the doctor is the insurance is going to, will it cover for if we write such a diagnosis? And sometimes there is also some conflict between the patient family and the treating team. We feel the prognosis is poor and we think that treatment is futile, whereas the family is hopeful and we're not able to offer end of life care decisions. So coming to some basic definitions. So terminal illness is basically an irreversible or incurable condition from which the patient is unlikely going to survive, and death is expected in the foreseeable future. So end of life care approach is an approach to this terminally ill patient, where the focus is from where you shift your goal from treatment to comfort. So where quality of life changes to quality of death, rather than focusing on treatment aimed. So mainly it is we don't want to prolong the patient's life. So that is what is end of life care. So what is the definitions? We come across the definitions of withholding of life-sustaining treatment, or withholding or withdrawal of life-sustaining treatment. So basically withholding is where we don't escalate treatment, where we don't offer new treatment options for the treatment who's already critically ill, where we offer end of life care. Withdrawal of care is basically we stop the treatment. Suppose the patient is on a ventilator or any hemodynamic support, we stop the already ongoing treatment so that we offer end of life care to such a patient. So the we must know when we initiate end of life discussion is we need to identify something called futility. So when a patient is critically ill, when it's not improving in organ supports, so we need to identify what is the treatment futile, the treatment that I'm going to put the subject patient to, where is it going to benefit him? So there is no absolute definition of futility per se. So futility, like if there's a treatment that cannot achieve an acceptable quality of life, and when there is no physiological aim at all. So examples of patients having multi-organ failure, end-stage pulmonary, renal, cardiac, hepatic diseases, or a multi-organ disease patient who's unresponsive to treatment for a few days. For example, a patient has a cardiac arrest and is in coma, has metastatic cancer, is in the ICU with multi-organ failure, where the chance of survival for the patient is very limited, or the chance of him living a meaningful life is very limited. That is what is called futility. So all end of life starts with futility. We identify futility and then move on. So we need to know what the four basic principles of end of life care. So first, most important principle is autonomy, where we respect the patient choices, what the patient needs, what the patient wants, what the patient family wants, what is their opinion. Like even the advanced directives is focused on the autonomy. And the next principle is beneficence, where we act in the patient's best interest, and non-maleficence, where where the concept is where we do not do much harm to the patient. And the concept of social justice is one important ethical principle, where we have when we in a resource limited setting, we are not going to offer therapies which the patient is not going to be benefited from. So once we've gone through the basics of end of life care and the basic definitions, the next we'll move on to the current legal situation in India. So is it safe to offer end of life care to a critically ill patient in India? So it all started in we have many laws. It started in 1994 and 2011, where the Human Organ Transplantation Act came up with the concept of brain death, and it addressed only the issues with relation to brain death, and there was no light thrown on withdrawal or withholding of support on other patients. So Article 21 speaks about right to life as a fundamental right. So in 2006, there was a medical treatment of terminally ill patient act, which said that you can withdraw the treatment of a critically terminally ill patient. A lot of rules. You need 3 practitioners, and the law said that withdrawal of care is not a crime, but it was a cumbersome process. So the highlight came in 2011, the classic, the Aruna Shanbag case, which showed where the Supreme Court said that passive euthanasia can be allowed in certain conditions. And this was the first time from the judiciary we had guidelines of how to withdraw a patient in the ICU. This is what the Supreme Court said, came up with the, this is how you should withdraw a patient in the ICU if the patient is terminally ill. So first you find out if the patient has an advanced directive or not. Then you get opinion from the HOD, 3 medical experts then they visit the family and surrogate. Then if they certify the patient is okay to go on a withdrawal or withhold, then you need to take opinion from the chief medical officer. The judiciary is involved here. The judicial collector needs to come in, and then the judicial magistrate first class comes and visits the patient and assess whether a withdrawal can be done. And it was quite, as you can see, it's a quite cumbersome process which can't be done in ICU routinely. So after this, in 2018, we had a law from the Supreme Court, Common Cause was Union of India, which laid down guidelines on advanced directives and for passive euthanasia, where we had some more clarity on withdrawal of care in the ICU. So again, the Supreme Court said it came up with this quite complex process, and it was impractical for us to use in the ICU. So based on this, the Indian Society of Critical Care Medicine came with a writ petition to Supreme Court. And in a few months back, in month of March, we had the judgment where on the writ petition was this Union of India. The Supreme Court laid down some clarity on how to withdraw a patient who's in ICU, who's terminally ill, if you have an advanced directive, if you don't have an advanced directive. So compared to the previous judgment, the court said that you don't need to have such a complex procedure. This is what the court said. You need to, in your team, in your treating team, if you're satisfied that the patient is terminally ill and the treatment is futile, so then you come up with a medical board in the hospital, the in-house hospital, where you have treating physician and 2 subject experts with about 5 years experience. They provide an opinion on withdrawal, and then they inform the family, and there is a secondary medical board who is an RMP in the same hospital itself, and 2 subject experts needs to certify that the patient can be withdrawn. So important to note, there is a timeline which is 48 hours, which was not there in the previous judgment, where the Supreme Court mentioned that all this should be done within 48 hours if you're going to take a decision on withdrawal or end of life care. So compared to the previous judgment, even getting advanced directive was much easier here. You don't have to go to the court. You can just go to a notary and you can do an advanced directive. And it was much easier compared to the previous judgment. So that is how the Supreme Court laid down guidelines. So we have a lot of end-of-life guidelines from various societies. In India, we have guidelines for end-of-life care from Indian Society of Critical Medicine, which laid down guidelines of stepwise how to implement end-of-life care. So I looked at various hospitals or health facilities where they have own institute guidelines. So one of the first centers is All India Institute, where they've come up with their own end-of-life care guidelines, which they implement in their hospital. Even Kasturba Manipal Hospital have a guideline called Blue Maple, which is end-of-life care guidelines, which I think is followed in all the Manipal hospitals. And in 2020, ICMR came up with one of the first guidelines for do not resuscitate. So it actually said that how to take a consent for do not resuscitation. So those are the first time where ICMR from national body public paper came where the guidelines on how to do DNR. Even in our hospital in NH Health City, we have a policy of end of life care. We have a checklist which we follow when we identify fertility and we go on to end of life care. So from all the previous slides, I think the best way to do end-of-life care in the current setting in India is the first step is assessment of fertility. Once you identify that the patient is not going to have a good quality of life, you identify that care is futile, and then you can have a consensus among your treating team is important. All of your treating team is on the same page, and then you go and discuss with the family and patient. So always go and disclose honest, accurate, be transparent about the prognosis of the patient, disclosure of prognosis to the patient or to the relatives. most of the times we end up having conflicts where we feel the patient is not going to improve. We have poor prognosis, but the family is still hopeful. So in that situation, maybe it is better to wait and give the family some more time to decide, some more discussions. You can always ask the family to take second opinions, and with time, I think family will come to. Usually, it happens that with prolonged discussions, I think we and the family are all on the same page in terms of end of life care. So then, when we have finally decided to go on for in pathway of withdrawal or withholding, we implement the process of withdrawal or withholding. The most important priority is keeping the patient comfortable, relieving pain with adequate analgesia. It is also important to document the process, entire discussion that you had with the family, and how you're going to do the withdrawal in the patient's file. So always it is a good habit to provide access to the family and end of life. Families are very much stressed. To make them comfortable, maybe provide more access to them in the ICU setting. If the family is very much anxious, there are a lot of psychological issues, you can always take help from the clinical psychologist or a social worker as well. So to conclude from all my previous slides, the law is clear from the latest judgment from a few months back that withdrawal and withholding of care in a terminally ill patient is permitted by the Indian law. It is not illegal if you go by the institute policy, and always try to document what is done accurately. Communication may be an important key with the family and patients when you offer end of life care. So we must provide a comfortable place for dying patients in the ICU instead of sending them discharge and medical advice where we don't get an opportunity to provide end of life care. So if there is any doubt, you can always follow up the local institution guidelines for end of life care or the guidelines by the Indian Society of Critical Care Medicine. I think the most priority is we need to give comfort for a dying patient. It must be the priority. Keep the patient comfortable so any patient in the ICU, once we have identified the process of end of life care, communication, documentation, and providing comfort to the patient must be the priority. I'd just like to conclude my talk. Any questions so we can always have in the end of the talk.
Thank you. Thanks, Dr. Shivakumar, for a brilliant presentation. I'll hand over to Dr. Muralidhar. Muralidhar, over to you, sir.
Thank you very much. Lovely presentations, and I would take a lot of pride and pleasure to introduce Dr. Srikanth, who is the consultant and head of physical medicine at my own place, Muralidhar Medical Center and Narayana Health City. He is talented in this specific field of rehabilitation, and his areas of interest include neurological rehabilitation, interventional pain management, neuromodulation, and community integration. Dr. Srikanth, thank you for joining us, and we are looking forward to your presentation. Dr. Srikanth.
Thank you, sir, for the very kind introduction. So I'll just move ahead. I'm sorry, there's some issue with screen sharing. I'll just reshare again because the slides are not moving.
No problem. Please do reshare.
So I'll just start off with a little background. The field of physical medicine and rehabilitation is a very recent one, and most people may not be aware of it. So it's basically a field that takes care of persons with disability. So we may deal with a lot of chronic neurological patients, and we also help to a large extent in transition of care from post-acute care, post-surgical care, and for those with disabilities. I'd like to state that I have no financial disclosure conflicts of interest with regards to this presentation. When we talk about those who have the misfortune of requiring intensive care and multiple organ support, we are very fortunate because you have very highly qualified people to take care of them. There is a lot of work that is already being done that improves their chances of survival. But we must also think about quality of life and functionality. So people who need organ support are at risk for long-term functional limitations. And these deficits have been documented where functional deficits, cognitive impairments, and deficits in activities of daily living can occur even beyond the hospital stay for those who have been discharged when there are no significant neurological deficits. The causes of functional deficit can be multifactorial. It can be their premorbid function, as Dr. Vimal has very informatively presented to us. The illness itself, the fact that they remain bedbound for a long state, they can be exposed to nutritional deficits, and because of multiple medications, this can itself confound the presentation. And they're at risk for developing multiple complications during their hospital stay: venous thromboembolism, pressure ulcers, ICU-associated weakness, which must not be confused with critical illness neuropathy and chronic inflammatory polyneuropathy. You have a separate entity of post-ICU syndrome, where you have cognitive and ADL deficits beyond the period of hospitalization that wasn't picked up at during the time of hospital stay. And you can develop contractures, aspirations. So you have a long list of complications. When we talk about mobility, patients who stay for more than 7 days in ICU are at risk for developing muscle weakness, about 25% of them. And that proportion increases when you throw in mechanical ventilation. So 60% of those who stay on mechanical ventilation for more than 1 week can develop muscle weakness. And it increases when when you have multi-organ failure. So you also have to consider the fact that there is an increased length of stay, increased resource use, and increased caregiver burden, and it also might affect the discharge status. It's important when you plan for rehabilitation to have proper documentation of all their impairments beyond issues of their airway and circulation and stability. It's important. Even documenting can go a long way. We may not have to quantify, but it's important to just mention it nevertheless. So you can have cognitive impairments, issues with mood. They might be delirious. They might be sleep impairments. You have pulmonary issues of aspiration, atelectasis. You might have patients who cannot express bronchial secretion, so they might need assistance for that. You might have patients who have postural hypertension and deconditioning resulting in contractures. Dyslipidemia and metabolic issues also confound their presentation. You have the risk of pressure ulcers, bladder and bowel dysfunction with being on the bed for a long time. And one also has to optimize the care of their medical tubes, such as a tracheostomy or a nasogastric probe and indwelling catheter. Make sure that you're prompt in revising them and reassessing the need for it, and address nutritional deficits and the mobility impairments. And if we have the time and resources, it's also useful to quantify the extent of these impairments. So cognition can be quantified with a mini-cog or a MOCA. You can assess dysphagia with bedside swallow tests, such as a water swallow test or a modified Mann assessment of swallow function. The secretion quantity from an ET tube or a tracheostomy can be graded and quantified in the times in terms of how thick they are, what is the quantity, how many times that it has to be suctioned in terms of grade 1 and 2, grade 1, 2, and 3. What are the segments of lungs that are expanding or contracted? When it comes to the hemodynamics, whether the patient has postural drop on high sitting. And when it comes to muscle status, a hand grip assessment is very useful. It's important to quantify the muscle powers. And when you are understaffed, you can use as start off by training therapists and your allied staff to document the muscle powers, and that will be very important when you deal with ICU-associated weakness. It's important to quantify joint ranges because you have the tendo-Achilles and knee flexors on the knees that are at risk for contractures. Pressure ulcers the importance of documenting the extent of involvement cannot be overemphasized. We have to use the National Pressure Ulcer Assessment Panel staging system, where you have stage 1 to 4. And when a nurse tells you that there is a stage 2 ulcer, always verify, because it can always be an S scar that can be communicated as being a stage 2, and beneath an eschar, you can always have an abscess. Always be aware of a patient who's, all not tucked in nicely, because then you might miss unilateral limb swelling, and take care that the tubes are positioned appropriately. It's important that you also try to quantify the functional status with the Barthel index, a Karnofsky performance scale, or a CATS disability index. And once we quantify the extent of impairments, these will be useful for us to set rehabilitation goals and execute them. So you can look to improve the patient's mood, communication function, and swallow dysfunction. You can look to improve their breathing ability and pulmonary function and ability to clear out secretions. You can look to prevent orthostatic hypotension. You can look to prevent deconditioning and muscle wasting and resulting contractures. Frequent position change will allow to prevent pressure ulcers. And one must also address their functional mobility in terms of planning to improve their bed mobility, transfers, and ambulation as and when it's feasible and safe. I wouldn't say that a multidisciplinary team is useful. I would say it's indispensable, because you cannot do everything on your own. And it's important to build up the resources and the team who can help you in this endeavor. And though it might seem that it adds more people and might confuse things, a team that communicates well and works as one unit really improves functional outcomes without adding too much of cost to the whole process. When it comes to the safety of interventions, in the last decade or so, there are certain specific points that have been mentioned, that as long as somebody has a fractional elevation of 0.5 to 0.6, has stable blood pressures on sitting, is not on pressor support, and maintains a saturation of more than 90% with respiratory rate less than 30%, without significant desaturation on mobilization. Mobilization is safe, and it has been documented even in ECMO patients, provided the prerequisites are met. You can always use a nice cardiac chair with a good back support and straps. You could use the assistance of a cardiac table to make a patient high sit. You can use a recliner wheelchair with a removable armrest, provided your tubes are mobilized safely and there's no jogging and tugging and disconnection. It's important to have an individualized therapy program that is daily. It is customized and as tolerated to the patient's ability, with a graded progression from passive ranges of motion to active assisted and active ranges of motion that involves trunk activities, strengthening, isometric strengthening as feasible, progressing to resistance exercises if indicated, that involves bedside high sitting, out of bed sitting, transfers, ambulation as and when feasible, and even cycloergometry as and when feasible. You could use devices such as a hoist, a tilt table, or a standing wheelchair in the rare instance. You could use neuromuscular electrical stimulation and provide galvanic stimulation to maintain the bulk of important muscles such as the quadriceps and the tibialis anterior, the large muscle groups of the shoulder girdle. Positioning in terms of preventing ulcers and also to optimize ventilation, such as proning, plays a big role in helping patients getting weaned off and also in preventing pressure ulcers. And it's important to educate the patient and the family as to what you're doing, so that during the visiting hours, even they can administer basic safe exercises as long as the team is competent in educating them about this. It's important to and ideal to measure outcomes with tests such as the timed up and go test, 3-minute or 6-minute walk test, the Barthel index, CATS index, and the functional independence measure. So I'll be talking a little bit about specific interventions for each of these impairments. So when you have a delirious patient, you can always, whether it's hyperactive or hypoactive delirium, you can try reorienting techniques such as playing pre-recorded messages of the patient and their of the patient's attenders, periodically telling them that they are in the hospital, they're going to be all right. And in addition to hospital visits, you can optimize the sound of the monitors, involve as much natural lighting in the design of your ICU as much as is feasible. It's important to optimize restraints. You can, instead of restraining the wrist, sometimes you might also want to consider restraining the elbow with a gaiter so that they don't feel that the hand is tight, and also keep informing the patient, reassessing if the risk of extubation is more, then you don't go ahead with removing restraints. But always it's important to pay attention to these issues. Communication, having a communication board so that patients' frustration is reduced, involving a social worker and the family, and talking to the nurse, how important a role that they can play in boosting the patient's morale. When it comes to swallowing impairment, it's important to assess and quantify what kind of impairment they have, whether it's for solids or liquids. Generally, with neurogenic dysphagia, you have problems with swallowing liquids. And so you look to position properly during swallow with techniques such as the chin tuck, modifying the texture of feeds, using techniques such as supraglottic swallow, double swallow, and a graded strengthening oromotor and pharyngeal strengthening program. When you want to prevent pulmonary complications and atelectasis, it's important to have the patient seated erect with cross-leg sitting or long sitting or high sitting as much as feasible. Employ techniques such as postural drainage, manual vibration, and percussion as much as is appropriate. Techniques such as segmental breathing help to expand closed collapsed lung segments, and if feasible, volume or incentive spirometry, using bottle oscillatory positive expiratory pressure devices to help mobilize secretions. It's very simple, having a jug of 10 centimeter height, using a large bore straw and dipping it in about 7 centimeters of water and blowing bubbles through it helps in mobilizing secretions. Using techniques such as huffing, cough strengthening also helps to get out secretions whenever feasible. This may not be for an intubated and ventilated patient, but maybe somebody who's on a tracheostomy or is recovering from an acute COPD exacerbation. Difficulty in weaning is a very sort of difficult area to address, but whenever feasible, it's always good to consider intermittent sedation, reconsider deep sedation as much as feasible, and use rehabilitative measures such as active passive cycling, passive ranges of motion, neuromuscular electrical stimulation, and to optimize bronchial hygiene and mobilize the patient as is tolerated, provided the prerequisites are met. When it comes to postural hypertension, in addition to the medical treatments, you can also use abdominal binders and elastic crepe bandages with graded verticalization. Many paramount beds also have a tilt function. So even the head end as well as the foot end can be elevated to small degrees of either 30 to 45 degrees, as long as it's safe and the patient is stable on that. So you can always try to gradually verticalize the patient. You might also be adventurous enough to use a tilt, provided the stability is ensured. Weakness and contractures, that is the crux of rehabilitation, where you need to prevent contractures from happening. That is possible using sustained stretches of holding each joint for the full range of motion for 10 to 15 seconds for 10 to 15 repetitions thrice a day, and by using orthosis as and when indicated. Then you go on to passive ranges of motion, active assisted ranges of motion, facilitation of muscle strength with compressions and neuromuscular facilitation techniques, weight-bearing exercises such as simple weight-bearing verticalization on a tilt or a standing wheelchair, using a hand cycle for ergometry. Even passive cycles have been used. I'll talk about that a little later. And neuromuscular electrical stimulation to maintain muscle bulk. It's important to ensure that strict position change is implemented in the ICU. Having a position chart and ensuring that it happens goes a long way in ensuring that we prevent pressure ulcers. And when it comes to mobility deficit and ADL limitation, you work on bed mobility, moving around in bed, high sitting with the legs dangling down, reaching activities as tolerated, out of bed sitting for about a period of not more than 1 to 2 hours as tolerated. You can facilitate transfers whenever feasible, such as moving the patient from bed to the same level surface. And that can be facilitated either mechanically or with a device assisted. Weight bearing with active standing or passive standing with a tilt table. Venous thromboembolism can be prevented by having a meticulous checklist, pneumatic compression devices, tender Achilles stretches and calf squeezes periodically delivered by the nurse, family, and therapist. And it's important to position the tubes and consider for weaning as and when appropriate. So when you talk about orthosis to prevent, so this is relevant for neurologically disabled patients. When you have poor plantar flexion power, you can use an ankle foot orthosis to prevent a tendo-Achilles contracture. You can use a resting hand splint to prevent wrist and finger flexion deformities. A knee and elbow gaiter to prevent knee and elbow flexion deformities. And it's also important not to keep the patient in too much of flexion at the hip flexion, because generally people tend to place the patient in long sitting, and to prevent the patient from sliding down, the bed is flexed at the hip joint. And so it's important not to keep that position prolonged, because even the hips can go into a flexion contraction. And whenever you prescribe an orthotic, it's important to assess the strength and have precautions such as graded wearing in time of the orthotic. Make sure that the orthosis itself doesn't cause any constriction bands or skin changes, and gradually increase the time of wear. We can use certain devices such as a hoist. Over here we have a lady who was about 120 kilos, and we were able to, and with a spinal cord injury, she was not able to move even from side to side. So we facilitated the family to get a hoist for her and shifted her out of bed and mobilized in a wheelchair. We can use neuromuscular electrical stimulation of the muscle groups that I mentioned to maintain muscle bulk. Here we have a transfer chair that opens out at the center. There's a clasp at the center, so if you release it, it opens out and widens. So you can just slide it under the patient and attach it back behind and get the patient out. You have a tilt table here, which helps in verticalization. So even ventilated patients can go on a tilt table as long as you do it safely. You can use an active passive cycle, which a passive cycle to help in maintaining mobility and joint range of motion, and when feasible, an active cycle as well. So they're not extremely costly. So if you want to use them for multiple patients, a hoist is available for anywhere between 40,000 to 1 lakh, depending on the company. A transfer chair is available for around 30,000 to 70,000 rupees if it's mechanical or electrical. A tilt table is available for around 30,000 rupees. A standing wheelchair is available for around 15,000 rupees. And you have a the passive cycle over here is available for around 7 to 10,000 rupees. And the humble manual cycle, active cycle, is available for around 2,000 rupees. So there are a lot of patients that seem to have been helped with rehab interventions, but a few come to mind. Now, Dr. Vimal just mentioned one patient who got discharged the other day, doing pretty well. These patients come in mind because initially when we set up the department, we didn't give them much chance, and it was very challenging to manage them. So we had a 33-year-old type 1 diabetic with ICU-associated weakness, was post-COVID, had muscle powers of 1/5, multiple pressure ulcers in the legs with a tracheostomy and on NG feeds with vocal cord palsy. He was bedbound and maximally dependent, stayed for 1 month in ICU, with rehab started in the ICU, extended into the ward for about 3 weeks, and had home-based rehab for about 2 to 3 months, who's currently back to work with muscle powers of around 4. We had a 64-year-old male who had triple vessel disease, acute kidney injuries, CREAP was about 5, gradually stabilized, had upper and lower limb powers of 2/5, spent 3 months in the hospital, 4 months of home-based rehab, who's now back to cooking and making mandala art, climbing stairs. We had a 50-year-old male stroke patient who wasn't given much chance. He had dyselecthylemia, had a very low GCS throughout, was in delirium for a long while. Once his electrolyte issues settled with the gradual rehab program of about 3 weeks, he's now walking with support. So this is on the left here is the patient with ICU-associated weakness. I don't have a photo of him right now, but he's walking without assistive devices. And the second patient who is right now cooking, his family made this mandala art piece as a token of their appreciation. And so to summarize, there are multiple issues to consider. It's important to assess meticulously and involve a multidisciplinary team and pay attention to detail with a commitment to extend beyond routine care. And a fractional increase in costs and effort have a large improvement in outcomes, can have. No evidence says that it doesn't improve mortality as such, but it can have long-lasting functional effects. It's important to create a good team and bring them together and face challenges as they come. And it's important to adopt advances and innovate as much as you can. Thank you very much for this opportunity. And it's been a pleasure to make this presentation.
Thank you, Srikanth, for that excellent overview of rehabilitation from ICU patients. Thank you so much.
Thank you, sir.
Very well done. Please stay back till the end because the discussion will take place after that. So I hand over this podium to Dr. Rajesh Shetty.
Thank you, Dr.
Who is the last speaker of the day.
I would like to introduce Dr. Karthiraj Natarajan, who is a consultant in the Department of Critical Care Medicine at Narayana Hrudayalaya Health City. His areas of interest are echocardiography and ARDS with the use of extracorporeal devices. He has got a lot of publication, including being a co-author in a chapter in a book, and he has published some case reports and reviews in few journals. Over to you, Dr. Karthiraj. And I understand you'll be presenting 5 interesting studies which have happened in the last 20 years. And all of these are landmark studies, which are especially important for trainees. So hopefully we'll find it useful. Thank you, Dr. Karthiraj.
Thank you, sir. Thank you for the nice introduction. So yes, mine is the last talk in the session. So without wasting much time, I'll just move forward. So I'm trying to talk about 5 interesting ICU journal topics, as sir said, which has been happening the last 2 decades. And then these are important because they have changed the way we are practicing critical care medicine. So we all know that this department, the critical care medicine is relatively new when compared to other super specialities, and a lot of interventions has been done previously on physiological and pharmacological basis, but when it comes to practice, there are contradictory results. So I just talk about 5 articles which has changed practice, which is different from what we thought from the physiological background. So first and foremost is the tidal volume used in ARDS. We have been using traditionally 10 to 15 ml, 15 might be much higher, 10 to 12 ml per kg of tidal volume whenever we are ventilating a patient, either in theater or in critical care unit. And then when they started managing patients with ARDS, what they noticed is that higher tidal volume seems to have additional stress and strain and causing further damage to the lung, causing what we called as villi, ventilator-induced lung injury. And animal studies seems to have proven that. And so there was a study which we call it as ARMA trial, which tried to see whether lower tidal volume will help and prevent further worsening and will it have a mortality benefit. So this study was done from 96 to 99 in USA, involving 861 patients, where there are 2 groups. In the lower tidal volume groups, they used 6 ml per kg of idle body weight. And next most important point is limiting the plateau pressure less than 30. So there are 2 catch in it, but plateau pressure is one. Why they looked into it? Because if 6 ml per kg is causing a higher plateau pressure, their strategy is to reduce the tidal volume further up to 4 ml per kg so that the plateau can be reduced less than 30. And then is the control group, which is 12 ml per kg with a plateau pressure target of less than 50. So this was a landmark trial which changed the way we start ventilating patients, not only ARDS patients, any of the patients in the critical care unit. So it has a significant mortality benefit and reduced mortality benefit of has a 31% compared to 39% in the high tidal volume group. And from this, after this trial, the standard of care for most of the patient in ICUs use a tidal volume of 6 to 8 ml per kg and assess the patient for that whether they are having a possibility of developing ARDS. And if there is a consensus there, yes, limit the tidal volume to 6 ml, even going up to 8 ml has been restricted. This is a landmark trial which really changed the practice. And this has been extrapolated in few perioperative care also. I think there were some studies which said that patients who are undergoing major abdominal surgeries, low tidal volume seems to have better outcome. So this has been extrapolated in theater also. And some cases they have started using low tidal volume, in which the anesthesiologist can tell us more later in the discussion. So why this low tidal volume came in? This is because of the concept of baby lung. When you look at the picture in the CT, this is how a patient's lung looks in CT, if the ARDS lung looks in CT. So this is only this part of the lung that gets involved in gas exchange. So whether you give 4 ml per kg or 10 ml per kg, only this gets involved in the gas exchange. So if this is the one which gets in the gas exchange, if you give more tidal volume of 10 ml, thinking that this part of lung also will get involved, this won't get involved. It over distance this lung and so causes villi. So that's why they say that you have to give a lower tidal volume, and more severe the ARDS is. That means if the severity is even more, if the area of the baby lung becomes even more lesser, so we might have to come down on the tidal volume even more further, 4 ml per kg. And sometimes we have to go even lesser, what we call as ultra low tidal volume ventilation, which is a different concept for which they try to do other measures to minimize the CO2 retention. So this is what we should know. It's because of baby lung. That is the reason why we have to go ahead with low tidal volume ventilation in patients with ARDS. So next, journal which I'm discussing about the use of prone ventilation in patients with ARDS. Yes, when we diagnosed ARDS right from the 70s, prone ventilation has been used for all the patients who had severe ARDS. But none of the studies showed mortality benefit until the PROSEVER trial. In fact, a meta-analysis in 2008 concluded that yes, prone ventilation improves oxygenation, but it is not associated with mortality benefit. So when the prone ventilation has so much of benefit and so much of improvement oxygenation, but it was not translated into mortality benefit till the PROSEVER study. So why? What might be the reasons? The PROSEVER trial investigation might have done a detailed analysis, and they included the right group of patients to show mortality benefit. So who are the right group of patients? First and foremost is that the patient with ARDS should be intubated less than 36 hours. And then they didn't allow them to continue with supine ventilation for longer time. So, and using higher PEEP and higher FeO2, they put in a criteria in such a way that patients who have a PF ratio of less than 150 with a PEEP of 5 is enough. They didn't go for higher PEEP, even 5 is enough, and FeO2 of 60 or more. So they started early proning. So what we call as early proning, maybe before they are proning a bit late. But so they started early proning that patient should be intubated less than 36 hours, PF ratio less than 150, PEEP of 5 is enough, and FeO2 60 or more. And then prolonged proning. The proning has been done for 16 hours, at least 16 to 18 hours. So this prolonged proning and early proning made a big impact, and then it had a significant mortality benefit. And this study seems to landmark trial. And so we started proning the patients earlier when they meet these criteria. So then why we know that prone has so much of benefit and why it didn't translate into mortal benefit previously? So what we might have happened is that, again, the concept of villi comes. So before this trial, the patient, clinicians should have ventilated the patient for longer time before proning, and then they might have used recruitment maneuvers, which has been shown to have more additional mortality benefit. And then they would have continued supine ventilation with higher PEEP, with higher FeO2, causing more harm by villi. And that might be the reason that when we proned late, it just improved oxygenation transiently, but the disease process or the inflammatory mechanisms continued to add insult, and then that's why there was a mortality benefit. So when you look at this diagram, so this is the same patient with the prone ventilation. Just the prone ventilation increased the area of the aerated lung. So prone ventilation seems to have a recruitment potential. Yes, it has a recruitment potential and redistribute a lot of gas in such a way that simple proning might be good enough in an early time so that we can have a mortality benefit. So PROSEVER trial is another landmark trial which helped us to identify the right group of patients and start proning early so that we can have a mortality benefit. The next comes the transfusion trigger in ICU. This is another landmark trial. So before this trials came, generally the hemoglobin target has been kept as 10, because with all the physiological thinking that yes, we need improvement, increased oxygen transfer and increased uptake will be there, especially in critical ill and surgical patients. So there has been targeting a higher target of 10 before this trial came. But this is a good trial, the TRIC trial, transfusion triggers in intensive care, done by the critical care Canadian critical care trials group. So they randomized the patient for a target hemoglobin of 7 or 10. So in the control group, if they'll be transfusing the patients only if the hemoglobin has reached 7 or less than 7. But in the So in the other group, they target a hemoglobin of 10. So when they looked into it, what they found was that when you look at the primary outcome, actually there's no difference in mortality. So we can even target 7 very easily. Need not have to target hemoglobin of 10 and then do with unnecessary transfusion. There is no mortality overall. But there was associated hospital mortality was higher in the liberal group. So when you transfuse target with a target of 10, there was an increased hospital mortality. And interesting finding is the subgroup analysis. So in the subgroup, when you look into it, when you look at the characteristics of the patient, like if the patient is having trauma, sepsis, or cardiac disease, there is no difference in mortality. But at the same time, when you look at the less sicker patients, that means the patient who had Apache score of less than 20 or age less than 55, it looked like it showed that liberal group had a higher mortality. So in ICU, the patients are relatively less sicker. We can boldly have a hemoglobin of 7, but sicker patient, no need to target because there's no mortality benefit. But this trial, in the conclusion, what they made is that they had an exception. You can, in medical ICU, we can target hemoglobin of 7, that's well enough. But they have an exception that patients with acute myocardial infarction angina, they said that maybe except these patients, for rest of the patient, we can have a hemoglobin target of 7. Though in this study, the cardiac disease patient, there was no difference in mortality. This study was not sound enough, or didn't have enough numbers to show that this cardiac disease group will have a mortality benefit or no difference in outcome when you look into the hemoglobin of 7. And previous studies before this in 1999, one more study came which said that patient with myocardial infarction, it's better to have a target of 9 or 10. So with those studies and with this not having enough number to prove just for cardiac disease patient, they said that for patients with acute myocardial infarction angina, yes, we can target hemoglobin of 9 or 10. And next, coming to the most important, the use of dopamine in critical care. We all know dopamine was the most commonly used drug, or first started drug in critical care till at least 2005 and even up to 2010, we can say. So because its ease of availability, Norrin was so easily available, and even in every nursing home, dopamine and dobutamine was easily available. So it's been first drug needs to be started. And other than that, starting it for shock, there was a physiological thing that patient was started on low dose dopamine, what we call as renal dose dopamine, there is an increased urine output. This is due to the natriuretic properties of the dopamine, and then it has some effects on the renal afferent and efferent vessels. So vasodilatory properties are there. So with these concepts, they all felt that okay, renal dopamine might be the first drug to start, and especially in patients who's having acute kidney injury. This is the physiological basis, but what the evidence showed us is really contradictory. So now I just give the first trial, which is about the use of renal dose dopamine. So low dose dopamine for patients with early dysfunction. It is done in Australia by the AN6 clinical trial group, in which they used what we call as renal dose dopamine for the trial group. So they gave dopamine of 2 microgram kg per minute for subgroup of patients who are at increased risk of renal failure. How did they classify these patients? These are the patients who had SIRS, because when this trial was done, SIRS was the clinical criteria to find patients who are sick. And then in this, if the patient is having urine output of less than 0.5 ml per kg per hour, at least 6 to 8 hours, or if the creatinine is more than 150 millimoles, which is equal to almost 1.7 milligram per deciliter, or if there is an increase in serum creatinine after admission by more than 80 millimoles or almost equivalent to 0.9 milligram per deciliter in less than 24 hours. So in this group of patients, they tried using dopamine with a placebo. It's a placebo-controlled trial. And then what they found out is that there is no difference in the peak serum concentration. It's not mainly related to mortality. The primary outcome was to see whether there is a difference in the value serum concentration, creatinine concentration. So there's no difference. So that means that even if the dopamine is started, even if it's associated with the increase in urine output, the worsening continued to happen when you compare it to placebo or dopamine. Okay. And other outcome, in look into it, there is not much difference in the ICU stay with the dopamine or placebo. There is no difference in the incidence of arrhythmias. Incidence of arrhythmias is most important thing which you should know, because I'll talk about arrhythmias in the next article. So there is no adverse effects. So when there is no adverse effects and clinicians tend to start using, because okay, it's not associated in any adverse effect and not much of difference is there, then why can't we continue to use dopamine? So that maybe the concept that low dose dopamine might have continued. But next came another trial, what we'll call the SOAP2 trial. SOAP2 trial is about comparison of dopamine and noradrenaline in treatment of shock. This is basically for patient with sepsis. SOAP is sepsis outcomes in acutely ill patients. So it's predominantly done in a medical ICU for patients who are with sepsis. But in this trial, they didn't classify and start it only for patient with septic shock. They started it for any patients with shock. So how they classified shock in this category, shock in this, if the MAP is less than 70 or SBP less than 100, despite fluid resuscitation. If the patient had shock, they started either dopamine or noradrenaline. These are wonderful blinded trial. So whether dopamine will be started, and if the shock worsened despite the maximum dose of what the trial drug is given, then open label noradrenaline is started, and despite that, if the shock persists, adrenal vasopressin is started as a rescue drugs. So what was the, okay, so before going to the results, when you look into it, the type of shock, 62% of the patient had septic shock, 17% had cardiogenic shock, 16% had hypovolemic, and rest of the miscellaneous, maybe some had anaphylactic shock, some had a drug-induced shock, which is into the miscellaneous category. So in this, what they found out is there is no difference in mortality as a whole. So either 30-day mortality, 6-month ICU. So there's no difference in mortality when you take it as a whole, including all the whole number of patients. But what they noticed is that there was a significant incidence of arrhythmias, especially atrial fibrillation, in patients who have been started on dopamine. Though arrhythmias were there, but there is no difference in mortality when you look at it as a whole. But when you look into subgroup analysis, and this is the hazard ratio we tell you, when you look into it, in hypovolemic shock, there is not much of difference. In septic shock, there is much not different. But patients who are having cardiogenic shock, there was a trend towards increased mortality who has been started on dopamine, and mortality benefit when they've been given norepinephrine. So in this, it says that maybe patient cardiogenic shock is better to start norepinephrine because they are already having tachyarrhythmias and tachycardias. Dopamine may increase the arrhythmogenic potential, so it may cause more harm. But Cardiac Society was not very enthusiastic to accept this. So there are a lot of changes in their in their guidelines. So when you look into this, after this trial came, our surveying sepsis guidelines clearly made these policies, and the guidelines made that dopamine is not part of the suggestions or recommendations. So first line, what we should start is the norepinephrine as the first line of vasopressin for a target MAP of 65. If the patient continued to have hypotension, we can add vasopressin. And if the patient is having associated cardiac dysfunction, we can start either dobutamine or epinephrine. This is a guideline recommendation, and they have taken out the concept of renal dose dopamine. So that is not been there from the surveying sepsis guideline. But when you look at the Cardiac Society, yes, they have not taken away dopamine completely. But what they said is that because obviously this is a trial which has been done predominantly on a medical ICU with septic patients. But what they say is that in cardiogenic shock, there are subgroups of cardiogenic shock is there, like classic wet and cold, cold and dry, and so vasodilated. So there are subgroup is there. So it didn't clearly say what is the shock and whatever. So what they said is that maybe in this classic wet and cold and even cold and dry, you can start either norepinephrine or dopamine. But in this, they're given a catch. What they say is that norepinephrine is preferred if the patient is having high heart rate or arrhythmias. Dopamine is preferred when there's low heart rate. But we have to be understanding of the fact that it is high risk for arrhythmias. But in other types of shock, they said that norepinephrine is the drug of choice. So this is how these trials have changed the use of dopamine. On almost in most of the medical ICUs, dopamine has been not been used or started, unless otherwise it's just an additional one to add as 5th or 6th drug in extremely ill patient. Then I come to the last article, which is use of hydroxyl ethyl starch in septic shock. we all know colloids has been regularly used previously. The rationale for it is that, yes, it is having higher oncotic pressure, and then the capillary leak might be lesser. We all know, even in normal patient, when you give a crystalloid, only 1/3 stays in, 2/3 goes out. And it may be even more for patients who's having sepsis and capillary leak, especially in ICU. So they thought that colloids might be of help, especially hydroxyethyl starch. So it was part of the guidelines. Even 2008 surveying sepsis guidelines says that you can use either artificial colloids or crystalloid for resuscitation. And then came the VICEP trial, which is the volume institution and intensive insulin therapy in sepsis. So here for volume, they compared it with hydroxyethyl, which is of higher molecular weight, 2 lakh molecular weight, 2 lakhs Daltons with 0.5 of degree of substitution, compared with ringer lactate. So they use hydroxyethyl maximum of 20 ml per kg per day, but RL as needed. But after reaching this, it is the clinician's decision whether to give anything further instead of hydroxyethyl starch. Okay, so in this study, what they found out is that actually the trial was not completely done because it was suspended. First is that regarding to the intensive insulin therapy. After the first safety analysis has been done, the insulin therapy arm has been completely taken because there was higher incidence of hypoglycemia in intensive insulin therapy. So that arm has been completely taken out, and they continued the study further only with the fluid management protocol. But after that, when they did an interim analysis, they found out that the 28-day mortality was significantly trend towards 90-day mortality significantly higher in the hydroxyethyl group, and mainly the incidence of renal replacement therapy was very much higher in the hydroxyethyl group. So because of these, after the interim analysis, the study has been stopped. So this is the first landmark trial which started an end to the colloid. I will say not colloid, especially the hydroxyethyl starch. Okay, hydroxyethyl starch, and then this is the probability of survival at 90 days, and after this came the success trial, which compared hydroxy in a different, because since this 2 lakh Daltons and then 0.5 degrees might be causing more harm, so they tried to try HES with a different molecular weight and different degree of substitution, which also said that there is an increase of mortality. And then again came the other trial called the chest trial done by the ANSIX groups. This also said that there is not much of difference and increase instead of renal failure. So after this, there is significant revision in the guideline in 2012, where they said is that they recommend against use of hydroxyethyl starch in fluid resuscitation patient with septic shock. So this is what about use of hydroxyethyl starch. But related to albumin, they say that don't use it initially, but you can use it if you have crossed a significant amount of volume resuscitation using crystalloids. So with this, I just end my talk. Thank you for giving this opportunity.
Thank you, Dr. Karthiraj. It was a very beautiful presentation of these 5 very important journal articles, which definitely have changed our practice. So thank you for that. Dr. Muralidhar, shall we go for questions now?
Yeah. I request all the panelists and moderators, faculty, speakers to switch on their videos, and you can go through the chat box and take one after the other. I have 2 questions sent directly to me. I'll come to them in between. So please look in the chat box. I think there are a couple of irrelevant questions which might have overflown from the previous webinar. So you may ignore that regarding the incision in lower segment cesarean section and about one lung ventilation. That those 2 can be skipped, but otherwise please go through the chat box.
Thank you, Dr. Muralidhar. Can I go with my question first?
Yes, of course.
And in the middle, I think there are 2 questions which are relevant to our topics. So we will go through those as well from the chat.
Yes.
My question was for Dr. Kiran Gowda. It was interesting that you said observational studies are actually as good as a randomized controlled trial, which is usually contrary to what we normally believe. And you said that a new recommendation gives the same value to observational studies to randomized control trial. I have two questions, regarding this. This will add even more difficulty for normal practitioners and trainees, because already there are so many studies for any particular clinical question, for that matter, any clinical decision you're going to take. And our usual practice was to go for a randomized control trial and do a critical appraisal of that. And if it was a good study and you can trust the internal validity and external validity, you will go as per the recommendation of that particular randomized control trial. Now, if you have to include observational studies as well, then there will be a lot of studies you have to go and assess, and then make a final conclusion. What do you suggest, in such a situation, how a trainee or a average doctor should go when making a clinical decision, when there are more observational studies? How should they assess and how should they decide? Is my one question. And the second question, possibly related to that, if for a same clinical question, there is one observational study and another randomized controlled trial, which one would you go for and put your trust in?
Thank you, Dr. Shetty. I think the trend now is to basically not to ignore observational studies. As when I was being trained, I was of the opinion, that is how I've been taught and trained, saying that randomized control trials always form the golden crust, basically, which we can absolutely follow the evidence and try to reflect that in day-to-day practice. But I think looking at the way things have evolved over the last 2 decades or the last 20 years is observational studies can have confounding factors, yes, but the portability or generalizability of the randomized controlled trials is not great. When a patient comes to intensive care unit at the door, he will not just come with hypertension or hiatus hernia, let's say, for instance. He will also come with hypothyroidism and other factors. So the way we look at evidence when it comes to randomized controlled trials, we cannot just include or exclude for that particular study design. We need to look for evidence which suits the patients rather than see for the patients which suits the evidence. That is the other way around. That's why observation studies have gained importance over the last couple of decades now. That's what I think it is.
Thank you, Dr. Kiran. Having said that, I would say that I would be careful, using observational studies as a basis of my practice. And if you, what I would advise the trainees is better to go with guidelines, because the guideline committees, especially if it is from a reputed institution and international one, they would have assessed all the studies and they would have made a recommendation. And they usually use this grade rating. And in the grade rating, most of the, until now anyway, I don't know if in future it will change. The observational studies are given a lower grading. So it will be interesting to see in future whether the guidelines will change. For now, I think guidelines still give a more importance to systematic review and meta-analysis and randomized control trial, and possibly lower grading to observational studies. To trainees, my advice is please, if there are more than one study and you don't have the time or capacity to individually appraise, better to go with guidelines, because experts would have sat and gone through all the evidence and come to a conclusion. And another point to add to that is probably well-conducted observational study may be much better than a poorly conducted randomized control trial. So probably this meta-analysis came to this conclusion because the quality of RCTs was poor, I think, and probably that's why there was no difference in whatever outcomes they were looking for in a randomized control trial and observational studies, and probably
I think
get the methodological quality as well.
Yeah, they did a huge. If I have to be, just a second. If I have to quote the evidence, they did a meta-analysis of 14 meta-analysis, which compare more than 1,000 pairs of observation studies and RCTs across 228 medical conditions. And they found out that the effect estimates from observation studies were not significantly different from RCTs, and they were basically matching the confidence intervals of the RCTs. That is how they made this conclusion. And it is not just 1 or 2 studies, it's more than 1,000 pairs. I know from the trainees' point of view, when they're just stepping into or opening up their eyes in their new career path, I think it's probably better to stick to guidelines, which would have taken into account all these. But for somebody who's having an advanced idea about all these observational studies, RCTs, and the study designs, I think it is. I just wanted to put across to the people that just the RCTs and meta-analysis is not the only way of looking into evidence. And if we look into intensive care unit, especially, how many RCTs have been done on intensive care unit, which are proved to be beneficial? Very less, just a handful of them. A, and B, doing an RCT on the intensive care is unethical. Because you cannot categorize patients, sick patients into category A or B just because we want to randomize and try to prove a point, looking for no confounding factors and trying to derive a cause-effect relationship. I think that is a bit unethical. That's why RCTs are not very popular, not easy to conduct on ITUs, as you might be knowing. So we can depend upon we need all sorts of studies, basically. I think, that's what my opinion is.
Thank you, Dr. Kiran. I think we will go to the next question, which is on the chat box, and it looks like it's for Dr. Shivakumar. We previously used to hear the term "do not resuscitate" (DNR) in the ICU. What are the challenges for an intensivist and the legal standpoint to execute this decision? Is it the same as patient not for escalation? Dr. Shivakumar.
Yes, sir. Thank you, sir. So basically, as I mentioned in my talk, do not resuscitate. So, from legal standpoint, like withholding DNR is just a component of do not. It may be a part. DNR just means that do not do CPR if the patient deteriorates as a cardiac arrest, whereas withholding or treatment means withholding. Non-escalation of therapy basically means you don't escalate all forms of care if the patient deteriorates. So in terms of legal standpoint, as I mentioned, based on the recent Supreme Court decision, withholding or withdrawal is not illegal. You can go ahead and withdraw. Follow the guidelines, like institution policies. I think documentation. If you go stepwise, go by the procedure, you will not be sued in the court of law that you're not you've done a mistake. So it's legal. It's not wrong in 2023 at this point of time.
Thank you, Dr. Shivakumar. I have got one question related to that. Do you practice withdrawal of life support in your institute?
Like if when we identify there's a futility in care, and we discuss with the family, and we follow once family discussion is done, and when we have a consensus among all the treating team that the treatment is futile, then if the family is in same page, then we go ahead and implement withdrawal of care or withholding. So most of the times it is withholding. Withdrawal is when we're in a situation where we have a brain dead, for example, a brain dead patient, and our patient is not for organ donation, then in that situation we would go for withdrawal. But we would definitely document all the discussions, and we would involve multiple specialties as well. If the patient is admitted under somebody, involve primary team. So we have a checklist for end of life care that we can follow and just document. So we do withhold. We do non-escalation of care as well.
Yeah.
Withdrawing, in my opinion, is active and withholding is passive. So the legal binding right now is such that we have moved 2 steps forward and 3 steps backward. So that's where we are, sadly.
Yes, I think as Dr. Karthik said, even though the new judgment has made it slightly easier to withdraw support, it's still a little complicated actually, and the 48-hour time frame is still very long, I think, especially in Indian setting where patient family have to pay for that 8 hours of ICU stay, and there is a lot of pressure. With the first judgment, no one had gone to the court to seek permission for withdrawal of support, and I would think even with the new judgment, I don't think anyone so far has gone to the court to seek permission and withdraw treatment, and possibly because of that there is a lot of variation in practice. I think very few hospitals actually actively withdraw outside the setting of brain death. I think brain death probably is a easier situation because they are legally dead. So there is no legal complication as such. It is the non-brain dead patients where in the Kasturba Hospital, Manipal, as you said, with the Blue Maple protocol, they do withdraw life support. AIMS is another hospital where they actively withdraw life support. And there is one army hospital. We at not all the Manipal hospitals withdraw life support. We at Manipal Hospital, Whitefield, we have our own protocol, which is based on the Blue Maple. And we are probably one of the very few hospitals where I think other hospitals also withdraw life support, but we document it as well, that we do withdraw life support. And our consent form is exactly similar to what is used in Kasturba Hospital and AIMS. Basically, there is a consultant called Dr. Naveen Salins, who is a palliative care consultant in Kasturba Hospital. He's the one who produced the Blue Maple, and the AIMS protocol is based on Blue Maple. And ICMR protocol is also based on Blue Maple, and ISCCM guideline. Actually, one of the main author is Dr. Naveen Salins. So all of them are made by him only. And our protocol is also based on that. So our consent form is based on that. And according to the legal experts, with that consent form, even though it is not as per the law, because you have to go to the district level court and you have to have a CMO permission and all that, which no one does. If you have an institutional protocol and you withdraw your support according to that, and everything is documented, they believe that you'll be able to protect yourself even if it goes to the court. And I feel if all the family members are in agreement and all the clinicians are in agreement, and if you go ahead and we withdraw, probably the legal consequences are not very high. It's our fear more than the real problem is what I feel. So far we have not come across any issues as such, and hopefully the practice will change, I think. So I wanted to know whether you do withdrawal of life support. I understand some people do, but they don't document it, I think, because in Indian context, that's another situation, isn't it? You don't want to go to the court, but you don't want to prolong the patient being in ICU as well. And there will be a lot of pressure from the family, and that leads to a lot of variation in practice, I think. Yeah, thank you.
Thank you, Dr. Rajesh. We are just about to cross our time limits. So before we close, can I request Karthik and Arjun to say their comments and if they want to add to anything which has already been said? Dr. Arjun, do you want to say anything?
No, that's fine. I think it was a fantastic presentation by all the authors, by all the.
Yes.
Thank you very much for it, and thanks Rajesh for helping us out moderate the whole show. It was thank you very much, Karthik and Dr. Rajesh.
Karthik, do you want to say something? You want to add?
Yeah, it was nice, sir. All the topics have been dealt with were really relevant and
yes,
to the point. All the speakers have done a great job sticking with the time also, and wonderful session. Thank you, sir. Thank you so much.
Thank you for joining. I had one question, if I may. Withdrawing support also includes that you stop feedings, right? Still feeding, is that correct? And if you do that, will it not be considered as cruelty?
So withdrawal means like if you ask, should we stop feeding for a patient where we have considered end of life care? I think all of the guidelines mention that you continue basic sedation, keep the patient comfortable. I think all the guidelines say you continue nutrition. There is no clarity on you should. There's no reference saying that you should stop feeding when you withdraw the patient. But it's varied practice. Suppose you want to stop feeds, there is no guidelines. You don't solve this. All Indian the guidelines. I think even the Manipal guidelines say you need to continue feeds. So if the patient is not tolerating feeds, if you want to extrude, it's okay.
For me, stopping feeds, I don't think so is cruelty, because many of these patients are under sedation, they are unconscious. The risk of aspiration and dying is much more cruel than, for the family who are by the bedside, caring for the dying family member. I think we've seen many times that patients have aspiration where they have vomiters. So probably that is something which would prevent me from continuing nutrition. But yes, in majority of the protocols, we have antiemetics as a part of the protocol, and ranitidine or along with ondansetron. So yeah, that is my opinion. But again,
just to take this scenario, if it was my father,
yes, sir,
and the intensively does not feed my father, I would
and emotionally for the family, it is always, oh, we are not, we are starving them to death. That is what the family thinks about.
Anyway,
On humanitarian grounds, feeding them and cleaning them seems to
Yes.
be an important concept. Even though we are withdrawing or withholding, I think those two things could continue, is my opinion.
Sure.
When you look at
Thank you.
withdrawal of support, I think even feeding needs to be stopped ideally, because even feeding just might prolong their life because you're giving some calories, you're giving some nutrition. So ideally, as per what they say that you have to stop everything, including feeding. But the consensus is the patient, the relatives are happy with it. If they feel that, okay, I want my relative to be fed until death, at least they have a satisfaction that patient has been fed until death. So for that, we can do, because whatever it is a consensus. Okay, what we need at the end is the satisfaction of everyone who's involved in it. So when it is involved, better to continue feeding if the relatives ask for it. But literally, ideally, better to do is stop feeding, because it might prolong life for another few hours, because you're giving some calories, I'm giving some nutrition, and we're obviously making the patient sedated, and maybe you're doing it with an unconscious patient, they may not feel it. So I think stopping feeding should be part of withdrawal of support, but it should be with a consensus.
Can I also make a comment,
thank you.
Professor?
Yes, last comment. Who said that?
It's Kiran here. Sorry.
Last comment, and then we have to close, because we have to feed
Yeah.
ourselves now.
Yeah.
Dinner time.
The practice in UK is basically about ANH, assisted nutrition hydration. There is no guidelines which say that we should stop any feeding for the patient who's terminally ill. But the way it is put forward is, the best practice, best practice recommendations, take into considerations the opinions and the beliefs of the families, and whether it's going to benefit the patient or not. So that is how they made a decision making process that involve everyone, and then go for a consensus, and then stop or continue. There are instances which I have also come across that patients who have been diagnosed as terminally ill and on the end of life care pathway, miraculously, in a very small percentage of patients, it has been the end of life care pathway has been withdrawn, because patients have survived and been discharged home. Very rarely, but I don't know the follow-up of when the patients would have died, but in hospital, I think small percentage of patients, they have survived. So taking these things into consideration, I think it's probably a good idea to just have a family and the team of clinicians, and make a decision that way.
I agree with Dr. Gowda.
Thank you so much, Dr. Belani. Nice to see you. And I think we have crossed the time limits, and the dinner is getting cold. I would like to thank all the speakers and the moderators, starting from Rajesh, Shetty, Arjun, Karthik. Then we had Kiran, Vimal, Shiva, Srikanth, and Karthiraj doing excellent job of this seminar. May I request Dr. Baljit or Sud to say a few words and vote of thanks, please. Belani, do you want to say something? I think we were there for some part of the session.
I was not able to join earlier, but whatever parts I heard, the presentations were outstanding.
Very
so
good.
keep up the good.
Thank you so much.
Dr. Baljit, are you there?
Yes, I'm there.
Yes, please.
Well, okay. Thank you so much for this, for a very pleasant task of the thanks on behalf of the New College of Anesthesiologists. We come to the end of a very, very interesting webinar on contemporary issues in ICU. Well, it was wonderfully moderated by Dr. Rajesh Shetty, Dr. Arjun Alva, Dr. Karthik, and of course, the Master of Ceremonies, Dr. Muralidhar Kanchi. And excellent presentation, as Dr. Belani also has commented. Dr. Kiran Gowda very nicely dealt the topic of evidence-based medicine. And there was a Frailty Index by Dr. Vimal Bhardwaj, very nicely explained again. And end-of-life care, I think there was a lot of discussion with regard to this particular topic. Very good points that were brought forth. And then ICU rehabilitation, a bit of a new terminology. And coming up, more and more in the future. And then, remarkably interesting ICU topics, 5 ICU topics, which Dr. Karthiraj had beautifully presented. I think these were the turning points, in various points of time. We changed the practice the way intensive care is practiced. Well, friends, we already crossed the time limit, and I would thank, of course, the moderators and the speakers for the excellent presentation that they made. And of course, there was equally interesting and very knowledgeable discussion thereafter the presentation. Thank you so much on behalf of Indian College of Anesthesiologists, and till we meet again next Wednesday, goodbye to you all, and stay happy, stay healthy.
Thank you. Thank you. I invite you for a virtual dinner now.
Good
Please
night.
join.
Thank you.
Thank you so much.
One day we are going to come for a real physically present dinner, not a
Absolutely,
virtual
absolutely.
one. We've had enough of virtual.
Anytime.
Thank you so much. Thanks a lot.
Thank you.
Good night, everyone.
Thank you.
Thank you. Thank you. Bye now. Bye-bye.
Thank you so much, sir. It was a lovely session, sir, and thank you everyone for sharing their valuable insights. We are more than grateful to everyone present here. We hope to have you again on our platform very soon for our next sessions. With all your permission, we are closing the session over here. Thank you and good night.
Good night.